Good Saturday morning. This is Dr. McDaniel. I'm a board-certified obstetrician gynecologist, and I have an office, a medical practice in Midtown Manhattan, New York City. And I'm bringing to you all things health-related for women. It's Saturday, so I'm actually obviously not in the office today. I am in New Jersey at the girls' horse farm. Girls take horse riding lessons, equestrian lessons every Saturday. And we're in New Jersey at Baymar Farms, where they've been taking lessons for the last 8 years. If you're new seeing the presentation, usually I'm at the office during the week. So they come from my Midtown Manhattan office, and on Saturdays when we're in town, which is most Saturdays, for the last 8 years, we've been coming to horse riding lessons for my two daughters. My daughter Jill is 13. She's been riding since she's 5, and my daughter Joy is 9. She's been riding since she's 3. So it's lovely coming out on Saturdays and communing with nature. Is what it feels like. It's very nice and peaceful. It's a great start to the morning. We're always 8 a.m. We have 8 a.m. Girls take private lessons because Jill's always had an issue with crowds, so we don't do the group lessons at 9. We come here at 8 and do a private lesson. So it just makes it easier because obviously at 8 o'clock there's usually no one else here. There's usually one other guy who rides, a man. He's quite professional, does a lot of jumps and horse tricks and things, and he usually takes one of these whole outside arenas. Occasionally he's inside. So there's usually maybe one other rider, but that's it. So it's nice. Right now there isn't anyone, and Jill just finished her lesson. Joy will be starting hers, so I'll go back in and take a quick peek at Joy once she gets warmed up, because they just transferred students. So let's see. The last presentation I spoke about vulvar fissures, and I'll finish that information up today. So vulvar fissures are little cracks or paper cuts of the vulva, which is basically the saddle area, apropos. The saddle area is anywhere where your bottom would touch the saddle of a horse, and that's the saddle area. Medically, we call it perineum. The whole crotch area from front to back is the perineum, and the saddle area is kind of a colloquial term for it. The vulvar fissures are most often at the area between the vaginal opening or the introitus and the anal canal, so right at the beginning of the anus. And the cracks usually are little paper cuts from up and down, so from the introitus to the anal area. Oftentimes, so that's the most common area. After that would be right at the vaginal opening, kind of 4 o'clock and 8 o'clock. And after that, will be kind of an up and down on the sides where the inner lips of the vagina are, the inner vulvar lips, the labia minora. There will often be third place would be little up and down cracks or paper cuts or slits on those inner labia, and the last area is usually going to be right above the clitoris. On either side, left or right, above the clitoris, little tiny cracks about the length of a staple. So those are the most prominent areas for the vulvar fissures. Now, most often when a woman has a vulvar fissure, she'll present with complaints of swelling, irritation, discomfort, oftentimes dryness, and then she'll say it feels like burning and paper cuts. And usually she'll say, I think I've been scratching and rubbing so hard that I have cuts or scraped with my nail the skin, because it feels like it's torn or there's a slit or a crack, and I'll often have to tell them that it's not from scratching and from rubbing with the toilet paper. It's because of the inflammatory process. So fissures occur most commonly due to an irritant, be it sweat. Any kind of constant wetness is the most common irritant. Could be yeast or fungal elements. Could be just constant sweat. Could be a vaginal discharge, either a heavy hormonal or a physiologic leukorrhea, or bacterial overgrowth imbalance. Lots of variations on the theme, but the theme is any kind of constant irritant mounts an inflammatory response. Sorry, and with that inflammatory response, the skin has changes that occur in the tissues, and because of those changes, it often becomes fragile and dry, or what we call excoriated. Sorry, I know it's hard to see me right now, but the sun is right behind me. It's a little difficult. Okay, there we are for a minute. Might have to walk backwards for a bit here. So the skin becomes inflamed and swollen or edematous and fragile and weakened in areas. We don't medically or scientifically, we don't know exactly why a crack or a break in the skin occurs, but we do know that it occurs once the inflammatory process has kind of maximized and the swelling and pressure has occurred inside the tissues. So that's the usual presentation. What we always do for the evaluation is we do an exam, and the most important is to always take a culture for a herpes culture of the fissure or the crack. We do a culture because less than 10% of herpes presentations will not look like a herpes outbreak. So we call them atypical herpes outbreak, or atypical symptomatic herpes. So as I think I've mentioned in previous presentations, that only 10% of people with herpes will have signs or symptoms that they have the infection anyways, but of that 10%, which is about 1%, they will manifest with what we call an atypical presentation. So the atypical presentation means it doesn't look like a classic herpes outbreak with tiny punctate ulcers. It looks like something non-specific. Oftentimes they look like fissures. So I always tell the patient that it looks like a fissure just from her irritation or infection or inflammatory process, but I am going to do a culture for herpes just to confirm that it's not an atypical herpes outbreak. And of course, a small percentage of the time we will both be surprised because it will be a herpes outbreak and not actually a fissure. So you have two things going on, because we know that herpes outbreaks occur when there's a breach in the immune system. So when the immune system is stressed or compromised, if that person has herpes, they're going to have an outbreak most commonly. And oftentimes, if their immune system is compromised or there's a breach in the system, they will often have a yeast or bacterial infection, because those are also what we call opportunistic infections. They take advantage of a weakened or a compromised immune system. So you will usually have two things going on when there's a herpes outbreak. You'll have herpes outbreak and you'll have some other sort of vaginal infection, kind of like a red herring. So you have two scenarios because of the environment. So I will always do a herpes culture, and then I'll take a look vaginally to see if there's a vaginal source for the irritant, do swabs and cultures of any vaginal discharge, and then treat the patient accordingly. Most often, or I should say always, vulvar fissures will not occur just from a week or so of an irritant. Working out, wearing sweaty wet clothes, or having a vaginal infection, or even less common scenarios is going to be someone who has urinary leakage or frequent stools or diarrhea. So there's constant wetness, constant irritant, stool salts, fungal elements, or someone who has had a cycle for a long time, so she's wearing pads, or she's having constant bleeding, so she's wearing peri pads, panty liners, shills. It's not going to be from a week. It's going to be from more like 2 to 3 weeks on average. So it's a chronic condition that will usually cause the environmental or the tissue changes to cause a fissure, not just something that's occurred over a few days. So we do the evaluation, I do the cultures, and then I also try to ascertain if there's a specific environment besides just the constant wetness, anything in addition that tips the patient over to have the chronic inflammatory changes and the fissures, and recommend obviously trying to eliminate the environmental factors that contributed to it. And then the treatment, first and foremost, is going to be to treat whatever's causing the constant wetness, and then to keep the skin cool and dry. And I will always give, if it's a young reproductive woman, someone who hasn't gone through menopause, I'll always give a combined treatment cream of an anti-inflammatory, anti-steroidal, anti-inflammatory, moderate steroid. The steroid helps increase the healing process, and the anti-inflammatory decreases the swelling. And I also have a combined cream that has an antifungal component. So that treatment works very well. If the patient applies it frequently throughout the day, they usually only need about a week. For mild to moderate vulvar fissures, they may need 2 weeks if it's been coming and going and coming and going. It's been for months. Occasionally, if someone's gone through menopause, and especially if it's the fissures around the vaginal opening or the fissures around the inner lips, the labia, then she will need a vaginal estrogen cream and the steroidal, usually not the antifungal. So she'll need a mild steroid, mild to moderate potency steroid, and also vaginal estrogen cream to rub on the area to increase the blood supply. Now, in severe cases where someone maybe has medical conditions that are compromising their situation, they have diabetes, cardiovascular issues, or problems with circulation, they may need nitroglycerin, which dilates blood vessels, increases the blood supply, and then they'll need the antifungal mild steroid or the mild steroid with the estrogen support in those scenarios. So it varies according to the condition. But a few other people are here now because it's getting later. But most frequently, it's going to just be a situation where they get the mild to moderate potency steroid, and they get the anti-inflammatory. There's a little kid taking they do pony rides here for kids who don't ride, so he's doing a pony ride. Joy's doing her lesson. Started too late to get Jill in, so we're just saying Joy today. So the treatment is always identifying the source of the chronic irritant, chronic inflammatory process, obviously eliminating that, keeping the skin cool, clean, and dry, sleeping without underwear so that the skin stays cool and dry and aired out throughout the night, not wearing close-fitting clothing, loose-fitting clothing throughout the day, no tight clothing, no thong underwear. That's just going to exacerbate things. And and the topicals, either the estrogen cream if someone's gone through menopause, the anti-inflammatory and the moderate potency steroid to heal the fissures and to help decrease the inflammatory response. And if someone has any kind of vascular or blood supply compromise, to add the nitroglycerin in order to increase the blood flow, which is going to help heal a chronic severe fissure in those scenarios. So I hope that's been helpful information on vulvar fissures. This is Dr. McDaniel at GYN Corner, and thank you for joining me. Please check out our YouTube channel that's also called GYN Corner. Please hit the subscribe and the follow buttons. Let others know with reviews and comments what you enjoy about listening or watching the GYN Corner presentations. And please check out the podcast. We're on 8 different platforms for GYN Corner. Most popular are Google Podcasts, Apple iTunes, Spotify, Anchor. And everyone enjoy the rest of your weekend. It's Saturday. And it's a nice day here in New Jersey. It's chilly, but it's nice and sunny, so can't complain. Thanks again. Have a great rest of your weekend, and bye.